Hi everyone, good Wednesday afternoon and welcome to Smart Health on Go Local Live. I'm Go Local News Editor Kate Nagel. I'd like to welcome on Brown Professor of Urology Simone Thavaseelan. Thank you, Doctor, for joining us today.
Thanks for having me.
Well, I appreciate it. Straight from surgery at the Miriam Hospital, now practicing with Brown Urology, expert in urology with a focus on kidney stones. Now, kidney stones impact 1 in every 10 people.
Yes, it's a very common disease. I see patients from walks of life and ages and genders with kidney stones. It tends to be a very acute event in their lives. It's usually one that has associated with a lot of pain. Most of my patients will describe it as worse than childbirth. But when we go on to diagnose this, there are a number of treatment options and solutions to treat kidney stone disease.
So tell us a little bit about your path to the Alpert Medical School. The focus on urology. Tell us a little bit about your decision to focus in this area.
Sure. I was a third-year medical student when I realized I wanted to do surgery, and I eventually figured that urology was really where I fit. It was a great combination of technology, various patient populations, a lot of approaches to how we treat disease, open surgery, endoscopic surgery, robotic surgery, microscopic surgery. And then I did a 4th-year away rotation at Brown. I was a medical student at Georgetown. I came and visited for a month. And I spent a month on service and fell in love with the program. I ended up doing my 5-year residency at Brown and then a year of additional training in endourology and focused on minimally invasive surgery and urology. I finished up in 2011 and then have stayed here in practice over the last decade.
Okay, recognized as a 40 under 40 for your expertise. Now let's talk a little bit, because there's several facets to this I'd like folks to know. One of the things that you've raised recently is the issue of temperature and living in warmer climates.
Sure.
And how that impacts folks with kidney stones, more prevalency perhaps in the south, but as we do see temperatures rise, why does temperature play such an impact?
Sure, there's a lot of interest in trying to look at the relationship between climate change and rising temperatures and kidney stone disease. In general, I think really the kind of fundamental issue is one of dehydration, and rising temperatures being associated with dehydration might predispose those patients who are at risk to make stones for a million reasons to have a higher incidence.
And folks who suffer from kidney stones, let's talk a little bit about perhaps predisposition. Obviously, you talk about the painlessness of the episode itself. Do folks really only know they have kidney stones, or could be predisposed to it that first time they encounter it?
Yeah, kidney stones tend to present very acutely and dramatically with significant pain, usually in the back or the body, maybe with nausea and vomiting, and then sometimes urinary symptoms, blood in the urine or going more frequently or urgently. They can also mimic the symptoms of urinary tract infection, having burning with urination or other discomfort when passing the urine. Sometimes they present with recurrent urinary tract infection. Sometimes you don't have any symptoms at all. We call those asymptomatic kidney stones. And then there's a number of medications and other health conditions such as diabetes, chronic bowel disease, previous surgeries like gastric bypass that can all put you at risk to develop kidney stones.
And you talk about some of those symptoms, again, kind of being across the board. Obviously, before we start even going into treatment, when to seek help from a medical professional.
Yeah, well, when kidney stones are small, they could potentially pass on their own. So many patients will have an established with a urology. They might enter a trial of trying to pass them on their own with the assist of pain medications and a hydration strategy. But if that's unsuccessful, then we do consider various surgical options.
And let's talk a little bit about that, what those surgical options look like. Obviously, is it based on the size of the stone? And then, we talk about stones. I mean, what are we talking about? What's going on? I mean, let's talk even about numbers.
Sure. So in general, if a patient has pain, then we're going to do an imaging study, and that can range from an ultrasound or an x-ray or a CT scan. That can help diagnose the stone location and the stone size. The kidneys filter the blood and make urine, and then it goes into the plumbing, the collecting system, which travels down 2 tubes to connect to the bladder, where the urine's then released. Anywhere along that path of that collecting system, a kidney stone can, in theory, develop. Once it drops into a very small tube, that ureter, it can cause a backup of urine into the kidney, which stretches the plumbing in the collecting system. That incites nausea and the classic pain symptoms that we see. The obstruction is ultimately what's causing. To really seek help kind of frequently or acutely would be if you have infection in addition to obstruction. And infection symptoms are usually fever. Okay. So if fever is present in the setting of having a history of kidney stones or pain that mimics kidney stone, that's a good reason to give us a call and to come in to seek evaluation.
So with treatment options, obviously you talk about surgery. Let's talk a little bit about that. When can stones be addressed at their location? When do medical professionals say we've got to work on getting these passed?
So based on imaging, if a stone is under 4 millimeters in size, that's usually around an 85% chance of being able to pass. Now, that's not without pain, grief, and discomfort, but probably without an operation. So for those patients, if we have, ideal enough imaging to suggest that it's a small stone, they have a great chance of passing it on their own. We might try that at home with medications called FlowMed to help pass the stone with relaxation of the ureter. If that's unsuccessful, then there's a number of operations that are considered to help speed up the process. This really depends upon a discussion between the patient and their surgeon, looking at their imaging carefully, deciding their individual characteristics, and talking about the risks and benefits and success rates of each of these procedures. But to give a global view of what that looks like, the first would be shockwave lithotripsy, where we use a machine that generates sound waves. These travel through the body to cause fragmentation of the stone inside the body.
Okay.
Nothing is done necessarily internally to the body with a shockwave lithotripsy. Other options include ureteroscopy and laser, where we put telescopes in the urinary channel. We don't make any incisions in the body to do this. The telescopes can enter into the natural passageway where we pass the urine, enter into the bladder, and access all the way up to the kidney. And then a very fiber is used to break up the stone. We then place a stent which helps drain the urinary tract. It's a temporary tube going from the kidney down to the bladder.
Okay.
The stent can be pretty uncomfortable, but it's usually very temporary and for a couple of days. If ureteroscopy and laser isn't ideal based on the location or the size of the stone, then other surgical options include going in through the back, where we'll make a very small incision using, again, a telescope to enter into the kidney, and then clear out larger stones, break them up, and suction out pieces. It's extremely rare nowadays that we might actually open a patient or make an incision and open the urinary tract to take out stones. Occasionally we do it, but it's quite rare in the age of endoscopic treatment.
Well, that was going to be my next question. Since you've been in the field, since you've studied it, here we are, 2020, you must have seen major advancements so far. Are you optimistic that there'll be continue to be advancements in that microscopic treatment, sort of the least invasive possible? Are you optimistic that this is going to continue to progress again for really that patient treatment and patient comfort?
Yeah, absolutely. Urology has always been a field where we've incorporated technology and innovation. That's kind of been the forefront of our surgical discipline. And so starting with opening up a patient to now using miniaturized telescopes is really a huge evolution in terms of recovery and speed to which we can get patients back to their normal lives. In my own practice, over the course of this last decade, for example, when I do surgery in through the back called PCNL, I'm now to do a procedure where we make a much smaller opening, tend not to leave tubes coming out of the back, and have a kind of quicker recovery or at least less time in the hospital. So I've definitely seen that in my own practice, especially over the last 5 years. I have every reason to believe we're going to continue to miniaturize the equipment.
And there have also been some exciting potential for, with the stones need to be passed, again, being able to address it from a patient comfort standpoint that way. Talk with us about how that will continue to progress.
Sure. Some of the symptoms that bother patients most are the stents. And I've been part of studies looking at trying to reduce the use of stents so that we really key on what the indications are that make most sense to place a stent, and thereby avoiding unnecessary use of the stent in other situations. I think the other big piece of this is prevention. Whereas we can address the acute stone event, preventing the next stone event is really kind of the next level for the patient. And so that usually consists of metabolic workup, where we test the urine, test the blood, and look at specific risk factors that might be contributing to a patient's stone formation.
And how does prevention work? As you said, those contributing factors, obviously it sounds like it could run the gamut, if you will. But are there really advancements in ways to prevent, as you said, that next episode?
Yeah. We analyze the urine. If a patient is a recurrent stone former or high-risk stone former, we'll do a 24-hour urine collection. At home, on a day that's convenient to the patient, they collect all the urine, we send it off to the lab, and analyze the amount of urine they make, the calcium levels, the oxalate levels, uric acid levels, really everything that might contribute citrate levels to their stone formation. Then we can individualize a plan, either with dietary manipulations or medications to help reduce that risk.
And have there been and medications addressing, as you said, the specific stone makeups based on that patient? Does that have a lot of potential?
Yeah, those medications that we have been using have been around forever, and that really hasn't changed that much. What certainly has is a kind of an explosion of interest around dietary manipulation.
Okay.
So the medications that we use are tried and true.
And addressing it from a dietary standpoint, but again, lots of developments of the stone and its passage as well. Before we let you go, I know you're busy, but just talk with us about working at the Alpert Medical School, obviously, with this team of experts, training that next generation of urologists. Is Brown really at the forefront of addressing kidney stones in the field of urology?
Yeah. I'm pleased to be the program director of our residency. It's an honor to be able to train the next generation of urologic surgeons. They spent over half a decade in training to be prepared to be able to be a urologic surgeon. And ultimately, it's really professionally satisfying to be able to take care of stone patients.
Well, I know that you just came from taking care of one this afternoon. I know you see them on a regular basis. Again, 1 in 10. But it sounds like there are some exciting advancements in the field, again, being able to address those patients. And hopefully we'll continue to see more moving forward. So thank you for joining us for Smart Health this afternoon live from the Alpert Medical School at Brown University. And thank you to Dr. Simone Thavaseelan for coming in, sharing her expertise and letting you know a little bit more about what to watch for with the treatment of kidney stones moving forward. So that's about it for Go Local Live. Be sure to see us when we pop back up tomorrow with more news, politics, lifestyle, and sports. I'm Go Local News Editor Kate Nagel.
Thanks.